Detection and identification of antibodies. The primary focus on identifying antibodies is identifying irregular or unexpected antibodies. These antibodies are not naturally occurring in the patient's plasma, but develop in response to exposure to foreign red blood cell antigens. The most clinically important unexpected antibodies are immune alloantibodies. So how these form, they are produced following red blood cell stimulation, which can occur through transfusion, transplantation, or even pregnancy. There are different types of antibodies in blood banks. We have the naturally occurring antibodies. These can develop without prior exposure to red blood cells. These form due to exposure to environmental antigens such as pollen, fungus, and even certain bacteria. These environmental substances can have structural similarities to red blood cell antigens, which can lead to the antibody formation. And we can also have passively acquired antibodies. These are antibodies that are formed in another individual and then transferred via plasma-containing blood components or intravenous immunoglobulin. These are not produced by the recipient's immune system, but may still be detected during antibody screening. For clinically significant antibodies, these are antibodies that reduce the survival of transfused red blood cells. Some characteristics, these are usually immunoglobulin G or IgG type. They react best at 37 degrees Celsius or body temp and or during the anti-human globulin or AHG phase of the indirect antiglobulin test. These antibodies must be identified during compatibility testing to avoid hemolytic transfusion reactions or hemolytic disease of the fetus in newborn. For autoantibodies and antibody detections, some definitions. So an autoantibody are antibodies that react against a person's own red blood cell antigen. For clinical relevance, their presence can complicate the detection of clinically significant alloantibodies, which are antibodies against transfused or fetal red blood cells. Why this matters? So autoantibodies can cause pan-reactivity in testing, masking, or even mimicking the presence of other specific antibodies that could be harmful during transfusion. So the purpose of the antibody screen, this is to detect clinically significant antibodies in blood donors, blood recipients, and pregnant women. This is required by the AABB, or the American Society of Blood Banks. And for prenatal significance, this is used in standard prenatal testing, and this is used to help assess risk of hemolytic disease of the fetus and newborn, and to determine the mother's eligibility for Rh immune globulin prophylaxis, or RIG. Some traditional methods of antibody detection. So we have the tube method. So this is a classic method for antibody detection in blood banking. So indirect antiglobulin test, or an IAT, is performed in the test tube. And for the procedure, so we have the patient's serum or plasma. This is mixed with the red blood cells of known antigen composition. Incubation allows for the antibody binding if it's present. After washing the cells, anti-human globulin, or AHG, is added to detect any bound antibodies. If you're in my class, there is a video on this slide, so make sure you take a look at that. First steps in the indirect antiglobulin test, So we have the immediate spin phase. This is optional. It's not always required, but it does help to detect cold reactive antibodies quickly. And then we have the 37 degrees Celsius incubation phase. This is the essential phase for detecting clinically significant warm antibodies. It simulates the body temperature by enhancing antibody binding. And then we have an addition of enhancement media, which is also optional depending on your results. This is used to increase the sensitization of the red blood cells. And some common enhancement agents can include LIS, or low ionic strength saline, PEG, or polyethylene glycol, and albumin. And then after all that, we'll do centrifugation and observation. So after incubation, tubes may be centrifuged and observed for hemolysis or agglutination. This will help to identify antibody-antigen interactions. The anti-human globulin, or AHG phase, also known as the Coombs phase, detects IgG antibodies or complement that are bound to red blood cells. A positive result indicates the presence of clinically significant antibodies. We also have Coombs control cells, or check cells. This is used to validate negative AHG results. It also helps to ensure the AHG reagent was added and active, make sure that it's all working. So you should always yield a positive reaction in a valid negative test during these control or check cell phase. For grading of reactivity, so the strength of agglutination or hemolysis is graded during all test phases, and this helps to assess the antibody strength and clinical significance. Some reagents we use for antibody screening are screen cells, and these are derived from group O individuals to avoid any ABO interference. The package is usually in sets of 2 or 3 cell suspensions, and each set comes with an antigen profile sheet. So this details the specific antigens that are present on each vial of cells. The antigen profile sheet is crucial for identifying the specific antibodies present in this patient's serum, and it also helps to correlate positive reactions to the corresponding antigens. Dosage effect. So some antibodies react more strongly with red blood cells that have a homozygous antigen expression, where they have 2 copies of the antigen gene. This phenomenon is known as dosage. So certain blood group systems that commonly show dosage are their RH, your KID, Duffy, MNS, and Lutheran. So those enhancement reagents we were talking about are potentiators. The purpose of these is it's added to the cell serum mixture before the 37 degrees Celsius incubation phase to increase the sensitivity of the antibody detection test. Some examples of these enhancement reagents are the 22% albumin, the LIS, and the PEG. For the anti-human globulin reagents, so we have polyspecific anti-human globulin reagent. This is also called polyvalent or broad-spectrum Coombs serum. We also have monospecific as well, and then we have the Coombs control cells, which, as mentioned earlier, is used as a control during the testing. Some advantages of the enhancement reagents is that it can increase sensitivity of the test and can also allow for shorter incubation time. And now we have gel technology. So this technology is an alternative to the traditional tube testing method for detecting antibodies in blood banking. So we have a microtubule, which is a small, narrow tube that contains a specialized gel medium. Then we have dextrin acrylamide gel. This gel fills the microtubule and acts as a medium to facilitate the separation of agglutinated red blood cells from the non-agglutinated cells during centrifugation. For the procedure details, so we have screen cells. These are red blood cells from group O individuals used for antibody screening. They have to meet the same antigen expression and quality criteria as in the traditional tube test we talked about earlier. For the suspension medium, the screen cells are suspended in a low ionic strength solution or LIS, which actually enhances the sensitivity of antibody detection by promoting faster and stronger binding between the antibodies and red cell antigens. For concentration, the screen cells are suspended to a concentration of 0.8%, which is optimized for this testing method. How it works. So during centrifugation, red blood cells that are coated with antibodies will agglutinate or clump and become trapped at or near the top of the gel. Non-agglutinated cells pass through the gel and form a pellet at the bottom of the tube. Some advantages. This method allows for easy visualization and interpretation of agglutination reactions. It is often more sensitive and standardized compared to the traditional tube testing. And the gel medium helps prevent false positives caused by rouleau formation, which is that stacking of the red blood cells that can actually mimic agglutination in the test tube phase. So if you're in my class, once again, there's a video on this slide, shows you how to do it, so take a look at that. So when reviewing antibody screen test results, we need to carefully analyze the reaction pattern, which can help determine if clinically significant antibodies are present. We need to consider the following questions too when we're looking at antibody reactions. So in what phase did the reaction occur? Phases refer to the stages of testing process where reactions can be detected, such as immediate spin, 37 degrees Celsius incubation, or the antiglobulin phase. Knowing the phase can help differentiate between cold reacting antibodies, which often react at immediate spin or room temperature, and clinically significant warm antibodies, which typically react at 37 degrees Celsius or the AHG phase. Another question is the autologous control negative or positive? The autologous control contains the patient's own red blood cells with their serum. A negative autologous control indicates that any reactions seen with screen cells are likely due to antibodies against foreign antigens. A positive autologous control may suggest autoantibodies or other nonspecific reactions, complicating the interpretation. Another question would be, did more than one screen cell sample react? Do we have more than one that's positive? So screen cells are typically used in sets of 2 or 3. If multiple screen cells react, this can suggest the presence of an antibody that targets a common antigen on those cells. If only one screen cell reacts, it may indicate a less common antibody or a possible false positive. Another question is, if so, did they react at the same strength and phase? So consistency in strength and phase of reaction across reactive screen cells supports the presence of a specific antibody. Variability might indicate multiple antibodies, weaker reactivity, or non-specific reactions. Another question is hemolysis or mixed field agglutination present? So hemolysis, which is the breakdown of red cells, can be a sign of certain antibody reactions or other processes. A mixed field agglutination appears as a mixture of clumped and free cells, which may indicate recent transfusion, chimerism, or other complex situations. Both findings will affect interpretation and may require additional investigation. Another question is, are the cells truly agglutinated or is rouleau present? So true agglutination occurs when antibodies cross-link the red blood cells, and rouleau formation will resemble agglutination but is due to the stacking of red cells caused by high protein concentration. So distinguishing between these is critical, as rouleau can give a false positive result. So we can do a saline wash or microscopic examination to try to help differentiate if it's actually agglutination or rouleau. Some limitations to the antibody screen. So the antibody titer is below the level of sensitivity. So if the antibody titer it refers to the concentration of antibodies present in the serum. Sometimes, though, the antibody concentration may be too low to produce a visible reaction in screening tests. This means the antibody may be present, but below the detection threshold of the test system. Low antibody titers can occur early after sensitization or as antibody levels decline over time. It's important to note that even low levels of antibodies may be clinically significant, especially in transfusion or in pregnancy. You can also have low prevalence antigens and antibodies. So some antigens occur infrequently in the population where they have a low prevalence. Antibodies directed against these rare antigens may be difficult to detect because the screening or panel cells may not express those antigens. As a result, antibodies to these low prevalence antigens may go undetected in routine antibody screening. And like that just said, it may not be in the antibody panel. So antibody screening uses a selective panel cells that express common clinically significant antigens. Those rare antibodies, or those against antigens not represented on the panel cells, will not be detected because they're not there. So this highlights the limitation of antibody screening and the importance of thorough clinical history. If there is a suspicion of a rare antibody, additional testing with specialized panels or extended antigen typing may be necessary. So antibody identification. A positive antibody screen indicates the presence of an unexpected antibody in the patient's serum. Further testing is necessary to identify the specific antibody or antibodies. Assess the clinical significance of the antibody. So does it have potential to cause hemolytic transfusion reactions or hemolytic disease of the fetus and newborn? Testing cells against additional red cells. So we can perform testing using a panel of additional red blood cells with known antigen profiles. This can help narrow down the specificity of the antibody by determining which antigens react and which do not. Panels may include cells with rare or uncommon antigens if needed, like mentioned earlier. For the importance of patient history. So patient history is critical in guiding antibody identification and interpretation. Relevant historical information will include any previous transfusions. So transfused patients are at risk of alloimmunization, where they can develop antibodies to foreign red blood cell antigens. You want to know their pregnancy history. Pregnant women may develop antibodies against fetal red blood cell antigens that were inherited from their father. We also want to know their age, sex, and race. These factors can influence the likelihood of certain antibodies or antigen prevalence. We want to know their diagnosis because certain diseases or conditions might influence antibody production. In medications, some drugs can cause drug-induced antibodies or actually interfere with testing. So a panel of red blood cells is used to identify specific antibodies in a patient's serum. This is typically consists of 11 to 20 group O red blood cell. Group O cells are used to avoid interference from the ABO antibodies in the patient's serum. Each red blood cell in the panel has a different combination of antigens from common blood groups like KEL and Duffy and KID and MNS. Antigen expression. The panel should include a diverse pattern of antigen expression to help distinguish between different antibodies. It is important to include cells with homozygous expression of certain antigens, so cells expressing 2 copies of the same antigen, because they often show stronger reactions like dosage, aiding in antibody identification. So for antibody identification, we use the eliminate or rule out antibodies that cannot be causing the observed reactivity in the patient's antibody screen. This will help to narrow down the possible antibodies that are present in the serum. So the process is you're going to review the reaction pattern of the patient's serum against the antibody identification panel cells. You're going to identify which red blood cells reacted and which did not. So for each antigen, check if the cells that did not react possess that antigen. If a cell has the antigen but shows no reaction, the antibody against that antigen is excluded or unlikely to be present. If a cell lacks the antigen and shows no reaction, it does not exclude the antibody against that antigen. So importance of homozygous expression. So cells with homozygous expression where they have 2 copies of the antigen gene usually show stronger reactions. A negative reaction in a cell with homozygous expression of a specific antigen strongly suggests absence of antibody against that antigen. Conversely, if a reaction is seen, it supports the presence of that antibody. So once again, if you're in my class, there is a video here that will show you the rule out method for antibody identification. So the evaluation of the panel results. So after we did the exclusion steps, so once the antibodies have been excluded based on their negative reaction or the rule out technique, the next step is to evaluate the remaining antigens. This involves checking if the pattern of positive reaction aligns with cells that are antigen positive. There's also an inclusion technique. So the inclusion technique is used to confirm the presence of specific antibodies. It looks for a consistent pattern of reactivity in all cells that express a certain antigen. If all cells positive for a particular antigen react with the patient's serum and all cells lacking that antigen do not react, it supports the presence of an antibody directed against that antigen. Some things to consider when you're evaluating the panel results is, do all the positive cells react to the same degree? So check if the strength of the reaction or agglutination is consistent across all cells that show positivity, and variations in reaction strength might actually suggest multiple antibodies or weak reactions. We also want to ask, do all the positive cells react at the same phase? So we need to identify if the reactions occur during the same testing phase. If it's during immediate spin, was it during the 37 degrees Celsius incubation? Sometimes these antibodies react in multiple phases or at different phases, which could indicate a mixed antibody population. We also need to ask, does the serum reactivity match any of the remaining specificities? So compare the pattern of positive reactions to known antigen profiles to see if they align with a specific antibody. This helps to confirm the suspected antibody by matching it to the antigen expression on reactive cells. The next one is, are all commonly encountered red blood cell antibodies excluded? Ensure that common antibodies like anti-D, anti-K, and anti-E have been ruled out based on the negative reactions or known patient history. Failure to exclude these can lead to misinterpretation or missing the actual antibody. We also need to, ask, is the autologous control positive or negative? The autologous control is the patient's own red cells tested against their serum. A negative autologous control indicates no autoantibody or autoagglutination, making it easier to identify alloantibodies. where if we have a positive autologous control, this can suggest the presence of autoantibodies or other factors like cold agglutinins, which could complicate the antibody identification. We also need to ask, is there sufficient evidence to prove the suspected antibody? So to confirm an antibody, you must have enough consistent positive and negative reactions that match the antigen profile. Insufficient evidence requires further testing or additional cells to confirm. And then, does the patient lack the antigen corresponding to the antibody? So that's the 3 and 3 rule. So for reliable antibody identification, the panel should include at least 3 antigen positive cells, so cells that express the antigen, and 3 antigen negative cells, so cells that do not express that antigen. This rule helps ensure that the antibody is truly reacting to the specific antigen and not causing nonspecific reactions. For phenotyping, so we have a positive direct antiglobulin test, or DAT. This is when a patient has a positive DAT. So that means their red blood cells are coated with antibodies or complement in vivo. This coating can interfere with phenotyping because the surface antigens might be masked or altered, making accurate antigen typing difficult. So if they've had a recent transfusion, so within the last 3 months, so if the patient has received transfused red blood cells recently, their circulation can contain a mixture of their own cells and donor cells. This mixed population can lead to mixed or confusing phenotyping results, since donor cells may express different antigens than the patient's own cells. Elution reagents. So these reagents help remove antibodies that are bound to red blood cells without damaging the red blood cell membrane, allowing phenotyping after elution. So we have chloroquine diphosphate, acid glycine with EDTA. So if the antibody coating resists elution, we would use an absorption method to remove the antibody from the cells. There are some challenges with recently transfused patients, like we mentioned earlier. They may show a mixed field reaction where both negative and strongly positive, which are 4+, reactions are observed in the same test. This happens because the patient has a mixture of their own red blood cells and the transfused donor red blood cells. Selected cell panels. These cells chosen for antibody testing should have minimal overlap in the antigens they express. Selected cell panels are especially useful when the patient has a known antibody and the technologist wants to check if there are additional antibodies present. Enzymes, these are useful for separating multiple antibodies present in a sample. So commonly used enzymes are physin, papain, bromelain, and trypsin. These enzymes modify the red blood cell surface by removing salicylic acid residues and denaturing or removing glycoproteins on the red blood cell membrane. The effects on antigens, so some antigens are actually destroyed by these enzymes, and others can have their expression actually enhanced. For neutralization, so neutralization involves using substances to neutralize antibodies in a serum sample. This process helps in separating multiple antibodies that may be present and confirming the presence of a specific antibody. So basically, neutralization helps to clarify which antibodies are truly reacting by blocking or absorbing specific antibodies, making interpretation easier. Then we have adsorption. So by definition, this is the process where antigen-antibody complexes form solid precipitates. These precipitates can be removed by centrifugation. So the purpose of this is to remove specific antibodies from the serum. For the method, we're going to add the target antigen to the serum. The antibodies will bind to the antigen, which will form that complex, and then these complexes will precipitate out of the solution. The precipitate is then removed by centrifugation, which will effectively deplete the serum of those specific antibodies. Homologous adsorption, so this uses phenotypically matched red blood cells instead of autologous or the patient's own cells. This is applied in cases of anemia or if the patient had recent transfusion. The purpose is to absorb antibodies when autologous cells are not suitable. Then we have differential adsorption. This is used when phenotyping the patient's red blood cells is difficult, and this can happen when you have a positive DAT or a recent transfusion. This can help differentiate antibodies by selectively absorbing them. The DAT, or direct antiglobulin test, this is used to detect antibodies coating red blood cells in vivo. This is used for investigating suspected hemolytic transfusion reactions, diagnosing hemolytic disease of the fetus and newborn, and to detect autoimmune and drug-induced hemolytic anemias. The methods we can use are tube method, solid phase adherence, or gel methods. Elution techniques. So the purpose, after detecting this IgG antibody on the red blood cells, the next step would be to dissociate or elute the antibodies from the red blood cell surface for identification. Types of elutions, we have total elution, which will remove all bound antibodies, and partial elution, which, you got it, removes only some of the antibodies. For methods, we have temperature-dependent methods, so heating or cooling to release those antibodies, pH adjustment, so altering that pH can break antigen-antibody bounds, and we can also have organic solvents, which are chemicals that can disrupt that binding. For antibody titration, the purpose of this is to quantify the amount of antibody present in a serum sample. So for method, we're going to perform a twofold serial dilution of the serum. Test each dilution against a suspension of red blood cells possessing the target antigen. For the results, it's going to determine the titer level, so the highest dilution showing a positive reaction. A fourfold or greater increase in titer or an increase in score of 10 or more is going to be considered significant. Once again, if you're in my class, there is a video on this slide, so take a look at that. So clinical implications of the antibody titration, we could do it in hemolytic disease of the newborn. So titration can help assess the risk and severity by measuring the amount of maternal antibodies against the fetal red blood cells. It can also be used in differentiation of anti-D antibodies, so it can help distinguish between immune anti-D antibodies produced by the patient's immune system and passively acquired anti-D from Rh immune globulin or RIG treatment. It can also be used for confirmation of HTLA antibodies. So HTLA antibodies are high titer, low avidity, are difficult to identify. Titration confirms their presence by showing high antibody levels with low binding strength. So we have to consider the frequency of antigen in the population for blood products and their compatibility. So the likelihood of finding compatible blood depends on how common or rare the antigen is. We also need to know the clinical significance of the antibody. So only antibodies that are known to cause transfusion reactions or hemolysis are going to be considered significant. For transfusion practices, if the patient's serum contains clinically significant antibodies, or if there is a history of such antibodies, transfused units must be negative for the corresponding antigen to prevent reactions. This ensures safe transfusions and avoids alloimmunization or hemolytic reactions. For cross-match compatibility, so the cross-match must show compatibility at the anti-human globulin phase, ensuring no antibodies will react with the donor red blood cells. For unit antigen typing, we can determine how many donor units need to be phenotyped to find enough compatible blood for the patient's transfusion requirements. So patients with conditions like sickle cell disease and beta thalassemia can benefit from receiving red blood cell units that are phenotypically matched. This approach reduces the risk of forming alloantibodies, which can improve transfusion safety and efficacy.